talk about is a lot of the yes, I'm doing things with Walter. Walter should be here. Where's Walter? So what I want to talk about is why should I care? So Dr. Don Berwick. Don Berwick, I don't know if you know the name. Don he was the founder in the 1980s of of the Institute for Healthcare Improvement in the U.S., which has become international. He was appointed as the head of the Center for Medicare and Medicaid Services in the U.S. by President Obama, and then he got kicked out by the politicians. The Republicans didn't like him. Anyway, Don Berwick made the statement, I'm competing with these guys here. Don Berwick made the statement several years ago that 30% of the cost of health care is waste. That just by being a little more efficient, we could save 30% of the cost. He's actually upped that recently to 40%. Now, he's talking about the U.S., but based on my experience, I've been doing this for 25 years, based on my experience, I really believe that things are just as bad in Canada, and I want to give this my view. Now, Charles mentioned, Canadian Medicare. Canadian Medicare funds doctors, hospitals, and medically necessary procedures. Those are the three things. And I want you to notice some of the things it's missing. So by definition, it does not pay for nurses, unless they're in the hospital, doesn't pay for drugs, doesn't pay for preventive care, prevention, because that's not medically necessary. That's saving something from becoming medically necessary. Doesn't pay for dental, doesn't pay for, because dentists are not doctors. Dental surgery covered, but doctors are optometrists. It doesn't care physio, occupational therapy, unless it's done in the hospital, home care, long-term care, and mostly community services, mental health, etc. So, my favorite one is the mental health thing. You were mentioning the mental health thing is that you can't get any medical services for mental health unless you have a breakdown, show up in an emergency department, and wind up with a psychiatrist in a hospital. We could have stopped that long before, way, way cheaper. Anyway, so we're wasting a ton of money. So, should these services be covered by provincial? Now, they are covered by provincial plans. Some of them, it's hit and miss. It's spotty. They don't have support from the feds. Well, they don't have support from the feds anyway. But anyway, why should I care if we're waiting for the doctors and the hospitals and the politicians to solve this question? We're going to wait for a long time, right? So it's not going to happen. Who can make this change? We can. It has to be a ground roots movement. I mean, it's just not going to happen. Andre Picard, Globe and Mail. We cannot deliver 21st century health care with 1950s system. That's what we're doing, right? It was designed for the delivery of episodic acute care. There are 55 specialties in medicine in Ontario. Maybe more now. But 55 specialties, and so when you have something wrong, you go see that specialist. If you have a chronic condition, you're screwed, right? We're not designed for chronic care, we're designed for acute care. We need to reshape things, we need to change the system, right? So I'm with Charles. So waste. So why do we get 30%? Let me give you some examples. How about this one? Waste from overcapacity and overstaffing. All right? And people go, overcapacity in healthcare? You're kidding. That's a joke, right? No, it's not. Right? So let me give you some examples. So I did a project at a place, nuclear medicine, that I'll call William Mosler. And so they called me up because they were worried because they had long wait lists for nuclear medicine. And so I had a student, I sent him out, and he started timing patients. What they were doing was they were booking people into 30-minute appointments. When he timed them, the average time for a patient was 17 minutes. So he said, why don't you book them into 20-minute appointments? You'll get 50% more patients. And they said, well, sometimes they take 30 minutes. Yeah, sometimes they take 10, right? Like, so they're sitting there complaining because they don't have capacity, when actually they had 50% excess capacity that was just not being used. I looked at endocrinology at the Cleveland Clinic. I had seen a similar thing. And doctors in hospitals are focused around, like, they were 30 minutes for a past appointment, a follow-up appointment, and 1 hour for a new patient. And that's what they define that, right? And so when I talked to the people who were booking them, they had one doc who regularly saw follow-up patients in 10 minutes. Okay? They kept time after time booking him in the 30-minute appointments. So at the end of the 10 minutes, the doctor would butler off, he'd be entering his email, the staff would spend half the day chasing the doctor to bring him back for his next appointment. What a dumb way, like, book it into 10 minutes, take 10 minutes, book it in 10 minutes. They had another doc who routinely took 45 minutes to do a follow-up. The patients loved them. Every Tuesday night, the staff was there till 7 o'clock at night. Hello, give him 45 minutes. Like, has anybody ever timed their damn thing? Not at all. Right? So we have waste of overproduction. And then the other thing I ran into several times is docs don't work on Friday afternoon, but the staff does. So here you have all the staff, like I've got clinics where the staff works 9 to 5, Monday to Friday. Friday afternoon, there's no docs around. The staff are sitting there playing solitaire. Right? On the rest of the week, the docs want to work overtime, so the staff is working overtime. So it's overcapacity. Either get the docs to work Friday afternoon. I'm a professor. I don't like professors are worse than docs. Even worse. Even worse. But, okay, so then let the staff have structured staff so that you have 10 hours, 4 days a week, and a 4-day week on a 40-hour day on Friday, something like, work it out. Healthcare gets frozen. There's poor workload measurement. We don't measure things. There's waste of time for undercapacity. Undercapacity, 10% of the beds in Ontario, of the hospital beds, are occupied by somebody who's supposed to be someplace else. Alternate level of care. 10% of the beds at any one time, today, right now. It's like, and they're not supposed to be there. Why aren't they there? Because we don't have the capacity, we don't have the capacity downstream. A lot of it is community care. Oh, did I mention that's not covered? Okay. So all kinds of issues. And I look from industrial engineering. I look from we talk about supply chain. And supply chain is about moving things through a system, and it's also about information and knowing where people are within a system. And in manufacturing, it's about product. In healthcare, it's about people. We have no idea where people are. We do not manage supply chain. We do not manage people well. I had one thing at Toronto Western Hospital. They asked me to look at their neuro ICU. And the neuro ICU sometimes runs out of beds. And so he wanted me to do a little simulation model. So I had some students, we did a simulation model. People were flying through there. And then we discovered, well, actually they had a step-down unit. The step-down unit would back up. The reason they backed up is because there was a ward that was full, and that backed up. But the ward was running 3 beds short because the nurses were off. And besides, they had people who were supposed to be in long-term care. They were ALC. And so all of these people, all the way through the system, are asking for more resources, more money, more beds. But actually, a couple of long-term care beds would have solved the problem. So people are not looking at the whole system. People don't look at systems in healthcare. They ignore it. And which is why industrial engineers are interested in healthcare issues. Okay. Processing waste. I love this. So lack of appropriateness. We do MRI CT scans without actually having appropriateness rules for who should get them. We have duplicate and unnecessary tests happening, and I don't understand. Andre Picard had an article last week about unnecessary tests that North York General had a real big cutback on. Unnecessary surgery. Unnecessary surgery. Here's a quote. Again, this is from Don Berwick. So Dr. Bernard Lowen is a cardiologist. He's the guy who invented the defibrillator. His group won the Nobel Prize in 1995. He concluded that about half, maybe more, of revascularization and cabbage surgeries in the US, nearly half of them actually do not relieve symptoms. They do not provide better medical, they don't work better than medical management. They don't stop lung for life, and they don't prevent future heart attacks. They don't do anything. 50% of cardiac surgery and cardiology is probably unnecessary. Now why, if you go to a cardiac surgeon, what are they going to do? They're going to do surgery, right? They haven't got somebody beside them saying, well actually medical management, cardiology is a better answer. So there's huge processing waste. There's Don Berwick, so in his list of his 30%, he listed things, failure of care delivery, poor execution, lack of adoption of known best care processes, patient safety systems, preventive systems. We don't do prevention in Canada. We don't do prevention. Kaiser Permanente, which is private in California, has a real emphasis on prevention. And why? Because it's cheaper. Because it actually saves money down the road to have prevention in primary care. We don't do that. Failures of care coordination. We don't have good care coordination. You go to it, you get sent by a specialist to your GP, you go back, you get on the wait list, you go through the next specialist. We do not have, we're beginning to develop family health teams, we're developing coordinated care, but slowly kicking and screaming, not working well. We have over-treatment, as I mentioned before. We have, in the U.S. they have high administrative complexity. We have that here too, not to the same limit. Pricing failures. Pricing failures are a huge cost. Things cost way more than they should. We really don't control it, we really don't manage it. We're starting to a little bit. We're starting to get a little bit better handle on it. But the pharmaceuticals, oh, it's criminal, right? Seriously. And then fraud and abuse, they listed, okay? Andre Picard, he has mantras about, in 2011, he listed a bunch of mantras about healthcare. The one is, he says, medicine is the easy part of healthcare. We need to invest in things that will make the population healthy, education, housing, the environment, meaningful work. Those are healthy indicators, not more medicine. If you don't count it, it doesn't count. That's my mantra. Like in engineering, like people don't know how many we did, or how many we have, or how many are on the wait list. And if you don't measure it, you can't manage it. Stop whining, start doing. Elected officials, business, and community leaders are unable to articulate a vision for healthcare. Rhetorical hand grenades are like unsustainable and out of control spending are counterproductive. Leadership is about finding solutions, and that begins with defining what